Phil, you're a co-host.
So just so everyone knows, if you are not a co-host, you won't be able to unmute yourself. One of the co-hosts will have to do it for you, just a heads up. Also, so everyone's aware, just your average participant is not going to be able to share their screen, unmute themselves. They'll only be able to chat to the co-hosts individually or all together. The meeting is recording and we've got a live transcription going. And Derek, if this is your account, then that recording and transcription will get uploaded to your account.
Okay.
Great, and I am here, and Derek, Henry, if you need me to do anything, just message me and I will do it on Teams. So I'm looking at the slides, they look good, and I think this will be interesting and I think it will go well.
Any thoughts on whether we want to allow Dr. Waldewender to unmute himself, make him a co-host?
I think that I think we definitely will want him to speak. When we did our joint forums with DOE, the very first one that we did, it was awkward because we hadn't allowed them to unmute themselves. So I think if we're going to want him to be able to speak, I think it's fine.
Okay, I'm going to admit him then and set up that.
So I'm assuming that once I hit, everyone can see the slides now. Is that accurate or no?
No.
Okay. It's weird because it takes over my Zoom like it's presenting.
So do you guys want me to be the one to present them? Because I don't mind doing that. It might be easier to have someone who's not speaking be the one who's presenting.
That might be easier, and then I can focus on my slides, and I've got a little script here for the end before we open it up to dialogue.
It does make it easier otherwise. If you are sharing your slides and speaking, you have to open up kind of multiple panels to try to see everyone and see the chat.
So let me share screen.
Hey, Jeff, we've added you and we're going to make you a co-host just to give you the ability to unmute yourself if you feel like weighing in. So just give me a sec. I need to find you.
I'm making him a co-host now.
Okay, yeah, actually you have to do it because you are the host. I don't.
Oh, interesting. Okay.
Yep.
Got it. Thank you.
Perfect.
So can you guys see the slides now?
Yes.
Yep.
Here's how let me just try advancing it before we hit no people. So did I now advance it?
Mm-hmm.
Yep.
Okay, perfect. I think we may want to start by not sharing them. I don't know, so that everybody can see and introduce people. What do you think works better, Henry?
I think it's fine to keep it up like this. That way, you know, we know exactly what it looks like when we're going into it. And then I think, Derek, are you just initially introducing Michelle to get things kicked off?
I can.
Yeah. So what's the next slide? It's the agenda. And did we decided Michelle was going over this?
Yes.
Yeah.
Yeah, so Michelle's doing the agenda and then these two slides, and then we're moving to Derek.
Yeah. Yeah, we have Michelle for slides 1 through 4. I kind of thought that she would do the initial welcome, but I'm fine to introduce her as well.
Tracy Gurney's in the waiting room.
Oh yeah, I see her. But it's the Tracy Moore that threw me.
Yeah, I think if we go in with this slide, I think that would be preferable.
So, I mean, I think Derek and Henry, correct me if I'm wrong, that we've done the kind of general like Zoom type intro first, and whoever's kind of quote hosting it would do that, and then Michelle would start her substantive discussion.
So you mean, are you talking about like sort of the general script on the process? Yeah, Henry and I
Yeah.
were discussing that. We thought that might make more sense to do right at the last slide when the presentation is done. And then it's sort of more fresh in everyone's mind on what the process is for commenting and so forth.
That's great. Whatever Henry's advice is, because I know it's worked well for the public hearings. I have not been on them.
Yeah, I think just I think it makes more sense to kind of go over the procedural comment stuff just at the end, because I think we'll be presenting for a while. So I think it just makes sense to admit, Derek, there's an admit all button. So when it's 5 o'clock, you can do that. And then maybe just give people 2 or 3 minutes to, I usually wait 5 for public hearings before proceeding. So you can admit everyone, say, we're just going to wait 2 or 3 minutes or 5 minutes to give people the chance to log on. And then we can proceed. And then I think you can just give Michelle the go ahead to go with her. And then Jenny, you can proceed to the second slide.
Now that sounds good. And I think it just makes sometimes doing some kind of just letting people know that we're waiting for the waiting room to clear, and that kind of generally speaking, the department's going to give its presentation. And then during the comment period, we'll give some instruction on how people can make their comments and ask their questions, just so they know that they will get instructions, but not actually giving them the instructions.
Sorry, can you say that last piece again, Jenny? I was trying to make some people co-hosts here.
I think that like, as you're letting people in, you can just explain that we're waiting, you know, that we're going to let people in, that there's going to be a department presentation, that there will be the opportunity for comment, but that we'll help talk people through how that process works when we get to that part of the agenda. And Michelle just poked her head in my office, so she'll be jumping on in a couple of minutes.
And Tracy just messaged and said she's back in the waiting room.
Yeah, I don't know what happened. I admitted her and then I admitted her again. She should be here now. Tracy, you in?
I am, yes, thank you.
Okay. All right, we ready to admit everyone?
I'm ready. All good.
Welcome everyone. We're just giving it a few more minutes. People are still coming in. Welcome everyone. People are still coming in. We're just going to give it 2 more minutes. All right, welcome everyone. People are still coming in, but in the interest of time, let's get started. So the process here is we're going to go through the slides. Various people are going to present, and there's going to be an opportunity to ask questions and have dialogue toward the end. Everyone is muted by default right now, and chat is disabled, but you can send messages to hosts and co-hosts. And we'll go through the process on how to raise your hand and ask questions toward the end when we hit that stage. So Michelle, if you are available and ready to present, then you're welcome to.
Sure, thanks, Derek. I think first we'll do a few introductions. Good evening, everyone. My name is Michelle Probert. I use she, her pronouns, and I am the director for MaineCare, which is Maine's Medicaid program. And thank you for being here this evening. Jenny, do you want to introduce yourself and the policy team?
Yes, hi everyone. I am Jenny Patterson. I am the Director of Policy for the Office of MaineCare Services. I use she, her pronouns. I will probably be quite quiet during this presentation, but I'll be available to answer questions. So the leads for my team are Derek Grant and Henry Eckerson, who can introduce themselves.
Hi, Derek Grant, MaineCare Policy, Legislative Liaison and Special Projects, and I've been working on this initiative with other staff since it was implemented in statute.
Hi, everyone. My name is Henry Eckerson. I'm a main care policy writer, and among others, I am responsible for the Section 25 dental services policy. I think we can go to Janie.
You're on mute.
Or Tracy.
Sorry about that. It didn't let me do it. Okay, my name is Janie Brand, and I am the Provider Relations Specialist for the dental policy.
Hi, everyone. My name is Tracy Gurney, and I am the supervisor for the prior authorization unit here at MainCare.
Phil.
Hi, everyone. My name is Phil Dubois. I am a senior data analyst on MainCare's analytics team. I assisted with the reg setting process, particularly in the benchmarking analysis that serves as the basis for the new rates.
Aaron.
Thanks, Henry. Evening, everybody. My name is Aaron Fodder. I am the Provider Enrollment Manager here for the Office of MainCare Services.
Jeff, do you want to quickly introduce yourself too?
Sure. Jeff Wallowender. I'm a general dentist, and I've served as a advisor for technical issues for the MainCare team.
If there's anyone we're missing, please speak up.
Tia, and I saw Shannon a second ago, but then she bumped off my screen. All right, let's keep things moving. And as folks come up during the presentation, then they can introduce themselves if they didn't already get the chance to. Although now I see Fran, I just want to give Fran Jensen, our medical director, an opportunity to say hi also.
Hey everybody, Fran Jensen. I'm the medical director for MainCare. I use she, her pronouns, and thanks everybody for joining us. I'll turn it back over to Michelle. Yes?
Yes, thank you. All right, so we will jump right in. We have quite an agenda for you this evening. First, just as a reminder, MainCare is Maine's version of Medicaid, and Medicaid is a federal state partnership that provides health insurance coverage, as well as in many, but not all states, dental insurance coverage for low-income individuals. And in case folks aren't aware, between Medicaid expansion as well as the pandemic period that we have been in, MainCare enrollment has grown a lot. And so we now provide health insurance to 1 in 4 Mainers. So sometimes when we talk to our friends or folks in the community or providers, people might say people on MainCare as though they're some separate, different group. People who are enrolled in MainCare are our friends and our neighbors, and a very important part of our community and economy. And so for all of you who are enrolled and serving MainCare members, we thank you very much, especially during this pandemic, which we know has been hard on providers, hard on the dental community. You all have experienced great challenges and come through those, and we appreciate that. On the next slide, I know that I am preaching to the choir here. Am I driving the slides or, okay, there we go, thanks. I know I'm preaching to the choir here, but I hope we all appreciate how valuable dental coverage is. We are super excited to be expanding our dental coverage to include adults. And we have also very intentionally taken this opportunity to update our dental benefit so that we are providing better evidence-based care for children as well. And also taken the opportunity to do a lot of work on improving our rates of reimbursement, which were long overdue for improvement. And we'll talk about that later in the presentation. So we all know that when we're talking about kids, dental care, even when they're still kids, it means that they do better in school. It's correlated with kids being in school more. For adults, we know that dental care is correlated with mental health issues and self-esteem and social relationship, as well as your job opportunities. And when we talk about the value of healthcare, we're talking about outcomes and quality, and we also are talking about cost. And again, I know I'm preaching to the choir, but as you all know, having good preventive care and having dental care on the front end can help you with costs and healthcare down the road. And for adults, a nearer term outcome of having Medicaid expansion and adult dental coverage is that we see much less utilization of the emergency department. So there are short-term as well as long-term impacts. And I say this in part because if anyone is here this evening who is not currently enrolled in main care, again, 1 in 4 Mainers need the value of this care, and we're really hoping to be able to expand access to those individuals. And thanks again to those of you who are very devoted to serving the population enrolled in main care currently. On the next slide, I already spoke to the fact that we recognize that COVID has been really tough on dental providers and members' access to care. And as you can see here, while our total spend on dental services actually increased from 2019 to 21, we just ran this math this morning actually, and it increased $1 million, but main care's enrolled population went up 46% over that same time period. And so that is clearly not the kind of spending increase you would expect to see given how many more people are receiving insurance through main care right now. You can see in the chart, that is the dental utilization. You see the abysmal drop-off that aligns with the outset of the pandemic. There was a rebound, but we are not seeing utilization up to pre-pandemic levels. And I'm sure that this is what many of you are experiencing on the ground. And lastly, unfortunately, we have also, related to all of these challenges, seen the number of service locations for dental services decrease. This does not include FQHCs. It's more complicated for us to be able to look at dental utilization in FQHCs. We recognize them as being very important service locations, but we weren't able to include them in the count here. So for non-FQHC service locations, you can see a decrease from 264 down to 202. So again, that's my quick spiel for why main care dental coverage specifically is so important, and also my acknowledgement that improvements to the benefit, improvements that we have made to our provider enrollment for all of main care, not just for dental, and improvements that we're rolling out for our reimbursement rates are all a piece of this picture that are meant to improve the quality of our services, make sure that you all have what you need to deliver the services that you provide. And we're really excited about our July 1 kickoff of all of this. So with that, I am going to turn things over to Henry Eckerson for the next slide. He'll talk a bit about the legislation that is helping to inform this work. Thanks.
And I think Derek is taking this slide.
Yep, I'll take this slide and the next slide. Again, my name's Derek Grant, and I've been wearing the legislative liaison hat with main care for probably a decade. And I think without fail, every single legislature, every single session, adult dental has come up and dental rates have come up. And it's always been something that is a good idea, but there's just no money in the budget. So I never thought we would see this, but here we are today, and it's been really exciting to work on a new initiative to make this a reality. So again, this came about in the biennial budget, which was LD 221, which laid out the framework for developing an adult dental benefit, comprehensive preventative, diagnostic, and restorative dental service. By July 1st, the department is authorized to adopt emergency rules, and in that process also to make sure that dental procedures and services are aligned with evidence-based care, medically necessary, to examine strategies to improve oral health education as part of that, and to develop some metrics to measure outcomes on the expansion. And also the department must work with providers to encourage participation in the main care program, which is part of this effort. Next, thank you. Again, as part of that legislation, it directed us to work with the main care dental subcommittee, which is main care advisory committee, MAC dental subcommittee. So we've been meeting with them for months now and developing the benefit in coordination with them, getting their input as stakeholders. And one thing that we've been hearing in that process was feedback on the provider enrollment process and the prior authorization process. So we've had conversations as part of this policy development internally with provider relations and prior authorizations to look at ways that we can make dentists' life easier. So the draft policy is nearing completion, and we started off by examining other states, what other states were covering in their Medicaid program, specifically based on provider input, stakeholder input. We looked at Vermont, Colorado, Massachusetts, North Carolina, Illinois, and Connecticut. And we included in that 2 commercial payers. And whenever there was questions, we also looked at the ADA recommendations. Inevitably, we had clinical questions, and we're thankful to have been able to hire Dr. Jeff Wallerwinder as a dental consultant, and he's been working with us in the latter part of the policy to finalize some of the clinical recommendations. And I'll hand it over to Henry.
All right, thanks, Derek. Again, my name is Henry Eckerson, and I am the Section 25 Dental Services Policy Writer. I'll preface my part of the presentation by saying that this is a draft dental benefit that is still subject to change. And as I'll note later, we encourage you to provide feedback on this presentation, which we'll take under consideration as we finalize the policy. Also, this presentation highlights many of the covered services and their limits, but is not inclusive of all services and requirements contained in the final policy. And for the purposes of this presentation, children refers to main care members under 21, and adults refers to main care members 21 and over. And with that, we can start. So most diagnostic services are covered for adults and children and do not require PA. COEs are covered once per 3 years, POEs 2 per year, and LOEs 1 per service location per date of service. In addition to these evaluations, comprehensive periodontal evaluations are covered twice per member per year. Providers may deliver diagnostic services via telehealth in accordance with Chapter 1, Section 4 of the Main Care Benefits Manual and the most current board rules and guidance. That's the Maine Board of Dental Practice. Most types of radiographic imaging services are covered, including intraoral radiographs, bite wings, TMJ anthrograms, and 2D cephalometric radiographs. And in addition to these covered services listed, pulp vitality tests are also covered once per member per date of service. Next slide, please. Preventive services do not require PA and are covered for children, and most preventive services are covered for adults. Sealants, oral hygiene instructions, and space maintainers in particular are not covered for adults. Profis are covered twice per year. However, providers may submit a PA for one additional prophy treatment per year when the member receives a score of 4 or 5 on the Health Through Oral Wellness Periodontal Risk Assessment. Not listed here, but covered are sealants at once per eligible tooth per 3 years. We have already received quite a bit of feedback on the proposed coverage for SDF and are taking the feedback and recommendations under consideration. And finally, space maintainers are covered twice per arch per lifetime for children. Next slide, please. Restorative services are covered the same for children and adults, and most do not require PA. Fillings are covered once per tooth surface per year. Providers that deliver the filling will be required to provide follow-up care for the filling during the 12 months following delivery of the service, and reinforcing pins are separately reimbursable. Crowns are covered for all members and require PA. The provider who placed the crown is responsible for recements and rebonds within 6 months of placement. Protective restorations are covered once per tooth per lifetime, core buildup with pins, once per tooth per 5 years, and pin retention, 1 per tooth per 2 years. Next slide, please. Most endodontic services are covered for both children and adults and do not require PA. Pexification and recalcification procedures are not covered for adults. Pulp caps are covered once per tooth per 3 years, and the rest of these services listed here are covered once per tooth per lifetime. Pulpotomies not listed here are also covered once per tooth per lifetime and should not be billed as part of endodontic therapy. Next slide. Most periodontic services are covered for adults and children and require PA. Pedicle and free soft tissue grafts in particular are only covered for children once per tooth per lifetime. Perio procedures that do not require PA include periodontal maintenance, scaling in the presence of gingival inflammation, and full mouth debridement. I'll highlight a few of these. Gingivectomy or gingivoplasty, gingival flap procedure, and osseous surgery have a combined limit of 1 per quadrant per 3 years. Periodontal scaling and root planing, 1 per quadrant per 3 years. This does require PA. And full mouth debridement, 1 per year, no PA. Next slide, please. All dentures require PA, and reimbursement includes the initial 6 months of post-delivery care, inclusive of adjustments, relines, rebases, and repairs. We are covering complete, partial, and immediate dentures. We are not covering overdentures. Complete and partial dentures are covered once per 5 years. Immediate complete dentures, once per arch per lifetime. Denture repairs and adjustments, 1 and 2 per denture per year, respectively. Rebases and relines, 1 per denture per 3 years. And pontics or bridges, 1 per arch per 5 years for children's anterior teeth, and a PA will be required. We are also covering replacing a missing or broken tooth, repair or replacement of a broken clasp, adding a tooth, and adding a clasp, which are each covered twice per member per year. Next slide, thank you. Comprehensive and limited orthodontic services are only covered for children once per lifetime and require PA. Orthodontic treatment must begin within 12 months after the department approves a PA. Once treatment has begun, the provider may bill and receive an all-inclusive payment for the orthodontic services. Not listed here, periodic orthodontic treatment visits require PA and are covered after an active, limited, or comprehensive orthodontic treatment period has concluded, or for treatment visits for members whose limited or comprehensive orthodontic treatment began with a provider or service location that is not able to complete treatment. Replacement of a lost or broken retainer requires PA and is covered twice per arch per lifetime. And removable and fixed appliance therapy, newly covered, is covered once per lifetime for each. Repair of appliance, once per arch per year, and re-cement or rebonds 2 per year. Next slide, please. Most oral and maxillofacial surgery services covered under Section 25 do not require PA and are covered as medically necessary for adults and children. Providers will be required to retain a narrative of medical necessity and preoperative radiographs as appropriate in the member's record. Covered services include extractions, removal of foreign bodies, abscess drainages, sutures, and excisions of lesions and tumors. Some oral and maxillofacial surgery CDT codes are being removed from the dental benefit so that they are solely covered and reimbursed under Section 90 physician services via their CPT code equivalent. We are doing this to ensure that there is not a rate disparity between CDT and CPT codes that represent the same services, which are set using different methodologies. CDT codes were removed based on whether the service was medical in nature and whether they were primarily performed and billed by oral surgeons who attest to Section 90, not 25. The removed codes had no or very low utilization by general dentists. Services being removed from Section 25 include open and closed reductions, osteotomies, and Lefort procedures. All maxillofacial prosthetic codes are also being removed from Section 25 as well to be covered by their CPT code equivalent in Section 90. Next slide, please. Sedation requires PA. Deep sedation is covered for 90 minutes per day, and intravenous moderate sedation is covered for 135 minutes. Non-intravenous conscious sedation and nitrous oxide are covered once per day and are covered without regard to the length of administration. Behavior management is covered 3 times per lifetime per service location when the behavior of the member prevents a covered service from being delivered. Providers should retain a description of the behavior that prevented a covered service from being delivered in the member's record, and behavior management should be reported in 15-minute increments. Visits to, not listed on the slide, visits to hospital or ambulatory surgical centers and extended care facilities are also covered and may be reported in addition to other services delivered during the visit. Consultations are covered 4 times per member per year and is reimbursable to the consulting doctor who gives their opinion or advice. We will also add D9992, dental case management, to the benefit and are currently discussing provider requirements and allowances for this service. And finally, occlusal guards are covered once per arch per 2 years. And that concludes the overview of the draft benefits, and I'm sure you'll want to know how this is being implemented precisely. So to meet the requirement of LD 221 to establish a new dental benefit on July 1st, we intend on implementing the new Section 25 rule on an emergency basis. So it's an emergency rule, and the emergency rule will be effective for 90 days starting on July 1st. Unless the permanent rule is adopted within that 90-day window. So to get that permanent rule in place at the same time or soon after the emergency rule is filed, we will also propose the Section 25 rule as a routine technical rule. This proposed rule will go through the normal rulemaking process with a public hearing and comment period. Once adopted, that rule will be effective until Section 25 undergoes another rulemaking again and is proposed and adopted. We are pursuing adopting the rule on an emergency basis, primarily because of the time it has taken to develop this benefit, and engage the proper stakeholders for feedback, such as we're doing now. And next slide, please. So we'll have a chance at the end of this presentation to get some oral comments, but we would appreciate your feedback and ask that you please send comments on the draft benefit to me by May 25th in writing as well. We will consider incorporating recommendations from this forum and the comments I receive into the emergency rule. You will also have the chance to formally comment on the proposed rule during the public comment period and public hearing, which will likely occur sometime in July. We will also provide the code level detail of the benefit by the end of this week on the webpage listed. And with that, that concludes my piece. And I can't remember who's coming up next. Is it Phil?
Thank you, Henry. So I'm just going to provide some highlights of the overall fiscal impact of the changes. So the overall fiscal impact of the proposed changes represents an additional $45 million in spending. This is on top of the $21 million that was spent in calendar year 2021 on Section 25 services. The $8 million of new investment is specifically due to rate changes. So that is to say, if the benefits stayed the same and utilization volume stayed the same, then rate changes alone will add another $8 million in additional spending for main care services. Another $37 million is the amount of investment we are anticipating for the adult benefit expansion. So this includes new codes, changes in PA requirements, and any additional utilization from adults once this new benefit goes live. And the expanded adult benefit will also mirror the same rate changes and investment. So the $8 million investment represents a 37% increase in overall spending. And the department is also prioritizing investment in diagnostic and preventive services. So if we look specifically at diagnostic and preventive rates, spending there will be increasing by around 70% on average. So this means for a provider of dental services who sees main care members, they'll experience an average increase in main care revenue by 37%. And obviously that increase will vary by provider depending on your mix of services. Next slide, please. So if you're looking for more information on rates, we held a forum on April 27, specifically for the purpose of discussing the new rates and the methodology for establishing those rates. The slide deck and a recording of that presentation are both available at the URL displayed at the top of this slide. Additionally, we've posted materials at this address discussing our draft rate methodology as well as those draft rates. I would just note that the rates are still in draft format at this point. They also have not been updated since we posted them online, and we still have a number of items under review and consideration at this time. But I would encourage anyone who is looking for more details on the rate setting methodology to take a look at these materials if you haven't done so already. And if you have any questions or comments in regards to the rates, our contact information will be displayed at the end of this call, and I welcome you to reach out to us. And with that, I will hand off to Aaron Fodder to talk about provider enrollment.
Thank you, Phil. Again, good evening, everybody. My name is Aaron Fodder. I am the Provider Enrollment Manager here for the Office of Main Care Services. And I want to start off by, talking about some common misconceptions. This goes for the existing dental providers that are part of the forum here this evening. I've often tried to make sure I hear feedback, the questions that are brought up over time, and I want to maybe, kind of review some of these items that seem to come up often when it comes down to enrollment. for any type of dental provider. The first thing is, do I have to pay an application fee to be a main care provider? That answer is no. For the enrollment process, dental providers, whether it's general dentist, hygienist, denturist, dentists who do orthodontia, you name it, none of them have to pay an application fee. Some of our provider types are required to pay an application fee. We do have a link and a list posted, but dentists are exempt. There is no application fee. Oftentimes we get the question is, do I have to gain additional licensure? The answer is no. There is no additional licensure that is ever required, not like a facility license or an agency license. The only license that really is ever out there is your own individual license that you get from the dental board. So again, no additional license is needed. Oftentimes I get questions about needing a copy of my diploma if I'm doing an enrollment case. Oftentimes I heard this probably more for our revalidation efforts, which started about 5 years ago, back in 2017. Oftentimes I get questions about asking for a copy of our diploma. Again, a copy of the diploma is not required. There have been some changes operationally, so if that was something that may have been requested during a revalidation effort, I can tell you going forward that a copy of the diploma is not a requirement. And then last on that list of common misconceptions is the overall time frame on how long it takes to be enrolled with main care. If you asked me 2 years ago how long it took, I could probably tell you it probably took a really, really long time, a pretty big pain point. But over the past couple of years, we worked closely with our enrollment vendor, Gainwell Technologies. We worked about changing some operational guidelines. We did some system enhancements to really reduce the overall time frame for an enrollment to take place. So if you're looking to be a brand new provider that does not take main care currently, we're averaging about 22 calendar days from start to finish. If you're an existing dental provider, if you have to do general maintenance, where maybe you're adding a new hygienist, a new location, you're updating some information on your provider file, that's taking an average of 8 calendar days. And then we really, really streamlined our revalidation efforts to bring that down to around an average of 5 calendar days. So again, 2 years ago, definitely a decent burdensome time frame it took to get any type of enrollment case to be done. But now, currently in today's time frame, a vast, vast reduction, which we're proud of. Next slide, Jenny. All right, so starting enrollment. So for providers who are anticipating or thinking about participating with main care and being brand new, our entire enrollment process, and this goes for existing providers as well, is all done online. There is no paper application process. It is all done utilizing our Health Pass online portal. For existing providers, you probably have already registered for a trading partner account, so you've got your username and password. But if you're brand new, that's the first step. Registering is as simple and as easy as probably registering for an Amazon account, right? Get your username, you get password, and you register, which will give you access to our online portal, which it's more than just enrollment. This is where you can go and request your prior authorizations, check a member's eligibility, and submit your claims. If we keep moving to the next slide. What I can tell you is once you're registered, on a link, there is a section for provider enrollment as it's shown here. This is where you would go to navigate to start any type of enrollment, whether it be revalidation, whether it be general maintenance, or enrolling with main care for the first time. Next slide. And this is a viewpoint of what that enrollment would look like. If you're an existing provider or doing revalidation, that information would be below. And you would have a link to start either that maintenance case or revalidation, or again, if you're brand new, in the yellow box, there is a link to start a new enrollment. Now, regardless of what you're doing, whether it's new enrollment, whether it's revalidation, whether it's general maintenance, we do have some help available. We do have several enrollment user guides online. We do have our provider services 1-800 number that you can call for assistance, or you can contact me directly. I know Everyone's contact information will be towards the end of the presentation. I know the presentation will be available and posted as it was discussed earlier. So my contact information will be there. But anytime you have any questions about enrollment, if you run into any issues, I always encourage you, my contact information is there. Feel free to utilize it and outreach me directly so I can assist as much as possible. Next slide. When it comes down to some enhancements, some stuff that we did to hopefully try to make enrollment easier for existing providers, especially those who are going to go through revalidation again. We've made some check marks and checkpoints along the way. As demonstrated in the slide deck here, our online portal has different tabs that house all your information that you navigate through. We've recently enhanced it with a percentage bar to show you how far you've gone if you're doing a revalidation case or a new enrollment. And if you're doing general maintenance, to help make sure that you've captured all the required information on any page, you will actually have different green check marks along the way, allowing you to be able to visually see whether or not you might have missed something to help guide you along the way. The whole point is so that when you get to the end to submit any enrollment case, you're not met with a host of questions and error messages saying you forgot items. We'll hopefully be able to guide you along the entire process and catch those things as they occur. And then I think the last slide, our next to last slide, Jenny, documentation. So I know I've heard oftentimes that paperwork becomes an administrative burden for the dental population. I can tell you our process is all done online. However, there may be on occasion where there might be some required documentation, stuff that might need to be printed out and signed. A couple of examples here, the main care provider agreement. If you're brand new to main care, you are required to execute a provider agreement. The only thing on this provider agreement is requiring your signature and date at the end. We do accept electronic signatures. So if you've got the capability to electronically sign the document, which is generally a PDF, you can upload that within your enrollment case, no printing, no wet signature required. Sometimes, depending on what you may or may not be doing within your enrollment, an updated copy of the Office of the State Controller's vendor form, or the State of Maine's W-9, as they call it, may be required. Again, that is a PDF. It can be done electronically. It can be electronically signed and accepted. Sometimes, on occasion, we may need a copy of your individual dentist license. Again, that can be uploaded within the maintenance case so that it's something that you do not need to print or mail in or fax in. It can again be uploaded electronically. Last but not least, if you're making any banking changes, or again, if you are a brand new provider, we do require all main care payments to be electronically deposited. There is, as you can see here, what we call an electronic funds transfer form. Again, this is a form, a PDF that can be edited online and it can be electronically signed, thereby hoping to alleviate any need to print documents and having things filled out by hand and signed by hand. And again, once but not least, I will mention that a diploma is not required for any of our required documentation for any of our enrollment cases. Next slide, Jenny. And last but not least, since I am speaking into this group, I did want to put it out there that our revalidation efforts did start 5 years ago. Main Care concluded that earlier last year, and we are due back up again. This is a requirement that is mandated by CMS, part of the Affordable Care Act that was passed over a decade ago. And all provider types, in this case here, dentists, are required to revalidate with Main Care every 5 years. That process is going to be starting up later this summer and fall. So if you are an existing provider and you did revalidation 5 years ago, whenever that might have been, 5-year mark starts this fall. We should be having more messaging coming out. We'll have some more information posted on our enrollment webpage about when you may be due for revalidation. As you can imagine, all this is done online, as it says here. But again, as a friendly reminder, revalidation will be starting again this fall. Next slide, Jenny. Because this presentation will be posted, there are several links and guides here posted for you on our enrollment webpage and enrollment resources, helpful information for you. I just want to pass along. And so that's available for your perusal as needed. And then I think the last slide on my part here is, I think, nothing else. So with that being said, I will turn it over to Janie and Tracy. Again, I want to point out that if at any point you guys as dental providers, brand new or existing, have any issues, you're more than welcome to reach out to me directly. Be more than glad to answer any enrollment questions and help out as I can. Jane?
Thank you, Aaron. Again, my name is Janie, and I am the Section 25 Provider Relations Specialist. I'm going to go over a few of the requirements for the PAs. There are several codes that were listed earlier in the slides that require prior authorizations, and there are different options that you can check on them. You can call the help desk, the customer service help desk, and the number is listed here. Or if you have access to the portal, you can go on the portal and you can check your code to see if it needs a prior authorization. Next slide. So some of the ways that you can get a prior authorization, you can download the paper form and you can fax it in. You do need to make sure that you have all of the required forms that are needed. If not, the prior authorization may be deferred. The examples of those forms are supplemental for dental, orthodonture, or dentures. Or you can log into the portal using your credentials and obtain the authorization number right away. And then you have that. And as long as you have your supporting documents, and those can be uploaded. And the next, I'll turn it over to Tracy.
Thank you, Janie. So for those of you who came in a little bit later, my name is Tracy and I'm the supervisor for the prior authorization unit. And so basically what happens after the prior authorization is submitted, there is then a clinical review. And the outcome of this review is basically you're going to get either an approval, a denial, or a deferral. And as Janie mentioned, a deferral means that there's additional information that is required. And so these letters are going to come to you via the postal service. You will get those. That way you will get a letter, as well as the member themselves will receive a letter. Next slide, please. And so a lot of times providers get very confused about what a deferral is, and they think that it might mean a denial. It does not mean a denial. It basically means that there's additional information that is needed before we can complete the full determination for whether or not this is approvable. And so it could be the fact that there could be one of those forms that Janie had talked about. One of those supplemental forms might be missing. It could be a clinical record that perhaps is not present, that is required, or it could be some clarification. Maybe the record is a little bit vague. And so after that information, you have 30 days to submit that information to main care, and then main care will then, once they receive the additional information, will make the final determination, and you will receive that final determination via the postal service as well. And so that is the end of my slides.
So we're going to open this up to comments and questions and discussions. Just let's go over the process here a little bit. Everyone is set to listen only mode by default, and the chat function has been disabled. So in order to make a comment or ask a question, please raise your virtual hand and someone will call on you. For internet users, raising your hand function is done by selecting participants or reactions from the meeting controls at the bottom of your screen, or you can raise or lower your hand by pressing Alt plus the Y key on your keyboard. If you're participating by telephone, you can raise your hand by pressing *9 on your keyboard. And once you do, please leave your hand raised until you're called on. We'll call your name and number and ask you to unmute your line, and that you should see a prompt to do that. Once unmuted, please begin your comment by stating your first and last name and the organization you represent, if you represent one. Please keep your comments brief in the interest of time so everyone has a chance. And at the conclusion of your comment, please lower your hand. Everything again is being recorded by Zoom, and there will be plenty of opportunities for feedback. If you don't have an opportunity here, there's contacts here. There will be opportunities for comments in the rulemaking, and all of these presentations and supporting documentation will be posted online. So, Mike Dowling.
This is Mike Dowling. I'm a pediatric dentist. I've been a main care provider for over 10 years, so I'm very excited to see some changes, both to the rates and to the process through which main care is administered. I do have some concerns what we've been talking about this evening, though. I know that the July 1st deadline is coming up. So as I understand it, these rules will be implemented on an emergency basis. And we have until next week to provide written comments on the rules. I believe we need actual copies of these, PA requirements and rules, and an actual time to go through them to provide proper comments. I look at my practice alone, and we have patients already scheduled for example, non-IV conscious sedation after July 1st. And I don't know what the prior approval requirements are going to be for that appointment. We're kind of left holding a lot of weight for how to actually implement these appointments without knowing what's going on. So I think we need a lot more information very quickly so we can respond to that. And we also need, as providers, a chance to an adequate amount of time to go through those and provide comments as well.
So Mike, thank you for your comment. And let me just start off by responding and just providing a little bit more background on the rulemaking process, because as you can see from the presentations today, we have been doing a tremendous amount of work to stand this up quickly, and it's complicated. So definitely we are very much understanding the need to have as much information and as detailed information as quickly as possible. And so that's why we will be posting the code level detail by this Friday, just so folks can review that. And again, in terms of the rulemaking process, that is required by law in order to have this program be effective. And so essentially what will occur is that we will get the emergency rule in place, but as Henry explained, we will also be going through the formal rulemaking process at the same time. So there will be further opportunities for feedback, but in order to actually have this be in effect for July 1, we do need to get that emergency rule in place. So, and that requires formal publication, filing with the Secretary of State, and all of that. So we're trying to make this work as quickly as possible while also listening to all of the stakeholder input. So there will be further opportunities for input, and there will be more detail that will be provided. So we are very appreciative of the need for that level of detail.
I see Ellen Brown Quinn has her hand raised. I'm going to ask you to unmute yourself.
Hi, I am Ellen Brown Quinn. I'm from the University of New England Oral Health Center. And I did come in a few minutes late, but one of the things that was concerning to me was the necessity for PAs for crowns. And currently, crowns are covered if the tooth is had endo. Are we going to be required now to have crowns that are in process right now and will not be cemented till after July 1st? are we going to have those pre-authorized now while we're in this transition?
Ellen, I think we'll have to take that question back, but effective July 1, if the PA requirement remains for the crowns, I guess I'll say preliminarily that they would have to have that service approved via PA.
Okay.
I don't see any other hands raised at the moment, but if you would like to make a comment, you can please raise your hand. And I see Mike has his hand raised again.
When can we expect a document that'll actually tell us what rules we are expected to follow on July 1st?
Jenny, I don't know if you have a better answer than me. I think I might have to, I think we don't have a specific date yet as to when the rule can be public.
I think I'm quitting.
So I think the document that we post on Friday will be helpful in folks understanding in a little bit more detail how this will work. And in terms of the formal rulemaking process, we're certainly working to get it out as quickly as we can. It is a legal process, so it's not 100% within our control how quickly the rule comes out, but we certainly understand the need to have that and to review it. So we are working as fast as we can.
We as providers also have an equal need to review that, so we're in compliance and we can plan accordingly.
I would just add, I mean, stay mindful that this was a Herculean effort. And not only was there just the work involved to develop the policy, but also making sure that the system is up to speed to be able to handle claims that come in. And as Jenny was pointing out, I mean, this whole process, what we send, this rulemaking process needs to go through the Attorney General's office for review and approval as well. So I think the answer you may not want to hear is that you might actually have to wait until July 1st to know what you're going to have to adhere to on July 1st. And then that'll be an emergency rule. And as Henry described, that will be coupled with a proposed rule that folks would be able to submit formal comments on.
I think there are some solutions, but I don't think we can offer anything more specific at this point. Allison P.
Hi there. My name is Dr. Allison Piper. I'm a general dentist in Belfast, Maine. And my question is, at this time, I feel that I have a pretty limited capacity to be able to see main care patients, but I feel morally obliged to help people who are in acute pain with extractions. So I find myself concerned about what I will and won't be obliged to do as a provider if I continue to take or continue to be a main care provider. And I'm concerned that I would have to drop out of the program if I am required to provide now covered.
You cut out there just one little bit, Allison. What was the last thing you said?
I'm concerned about that I would have to cease being a main care provider if I'm obliged to provide all of the services that are now covered.
So under current rules, dental providers are, and any provider is allowed to limit the number of main care members that they see, their panel size. However, they are required to provide services and the quality and quantity that they would provide any other patient that they're seeing who has a different payer.
Okay, so I would be obliged however many main care patients I take to provide whatever services main care covers.
Correct.
That's unfortunate. Because it's going to oblige me to probably have to drop out of the program because I just and there'll be people who need the extractions. I believe I'm the only provider anywhere in my area that accepts main care for anything at this time. I just don't know what folks are gonna do. Because I would rather, and it's, this is such a, much bigger question or a much bigger point of, a provider saying, well, I can do this. I can get people out of pain. Like I'm willing to do that because obviously I don't know what the new rates are. But if the rates that were being reimbursed don't cover my, significant expenses, then it becomes impossible for me to see patients. And, again, if I would rather see, 50 people in acute pain who would otherwise go to the emergency room a year than do provide all services for 2 in a year. And I understand you guys, have very limited capacity to affect that, but it's very concerning to me that I would have to drop out of the program.
Well, we'd appreciate having your comments in writing. If you'd like to send that to me, I'd appreciate it.
Absolutely, for sure.
And again, just to be clear, because we didn't spend a whole lot of time on rates, but there were 2 budget initiatives that were approved by the legislature last year. One was to expand the adult dental benefit, and then the other was to increase reimbursement rates. And so there is a substantial amount of material that is posted on our website about the rate initiative. We didn't spend a lot of time on it today, but both of those initiatives will be included in the rule that we adopt, both the new rates and the new benefit.
Okay, thank you.
Kate Hopkins, I'm going to ask you to unmute yourself.
Hi, this is Kate Hopkins. I'm the CEO of Community Dental, and we're have 5 locations in Maine, including in Portland. And I don't know right now if we're the largest provider of main care services for dental, but we're probably one of them. And I guess I just wanted to have someone explain a little bit the rationale behind adding a prior authorization to the different sedation categories. Is that because that was being done in other states? If somebody could explain that a little bit, and then also for scaling and route planning as well. These kinds of, well, I think that my guess is you probably try to expedite this as much as possible. It is an additional burden for any office, and for an office like ours that has 2 oral surgeons and seeing over 35,000 patient visits a year, we would expect that something like adding PA services for these would probably require us to add staff just to be able to manage that process, which is a burden that is difficult for a nonprofit to take on at this time.
Yeah, we do understand your concerns. Those PAs in particular were, we are requiring PAs for those services because of the way other state Medicaid agencies require PA, and because it was the suggestion, the conclusion of our clinical assessment of those services, they should require PA. Does that answer your question?
So it looks like Michelle Probert, did you have a comment? I see your hand is up.
Yes, can you hear me?
Yes, we hear you.
Great, thanks. I actually wanted to comment on the previous commenter and just to be clear that absolutely hear the concern that you spoke to in terms of ability to provide a full array of dental services. I second Jenny's recommendation to check out what our proposed rates will be, because that may impact the calculations that you need to make for your practice. And then I also just wanted to make sure that everyone was clear that this is a federal level regulation. And so it is not something that we are able to change within the state of Maine. We're required to make sure that individuals who are receive their health insurance or dental insurance through Maine Care don't receive differential treatment. And again, I hear where you're coming from, but I just wanted to make sure that folks were clear that this wasn't an area where we have flexibility.
Thanks, Michelle. And I think I didn't give Kate the chance to respond. So if she wanted to follow up, I'd ask her to do so now.
Yeah, well, I guess it's not that, it somewhat answers my question. I just would, and we'll certainly submit this in writing, but I would say that, prior authorizations under the best of times impact access to care for very vulnerable patients. And when you're talking about the challenges of, providing these services, and the additional costs that we're going to have to incur, again, you're putting some of the greatest burden on, these services on providers who, we're shouldering much of the care of these patients. And I understand that the hope is that more private providers will start to accept Maine Care, but for right now, we see most of these patients, or if we, the nonprofits and the FQHCs see most of these patients, and it is a challenge for us to have to add additional staff just to deal with prior authorizations. So that's my comment.
Thank you very much, Kate, and definitely send whatever you can in writing to me. That would be great. Sharon, I see Sharon Stanley. I see that you have your hand raised and you should be able to unmute yourself.
I just want to confirm that I understood a previous sort of question and response. If you take Maine Care patients and have other patients with other payers, you're just saying that you have to provide the same services to both categories of patients, right? Not that you have to provide every service under the Maine Care rule. Is that correct?
The services, if you provide a select set of services, you cannot, you have to provide those services to Maine Care members in the same quality and quantity that you would any other patient.
But if you don't provide some of the services that are now available, you don't have to start covering them.
Right. If you, if you're an endodontist, you don't need to start covering perio services. If that's what you mean?
Yes.
Yep.
Thank you.
Yep. I don't see any other hands raised at this time, but if you would like to make a comment, please raise your hand and I can call on you. give it a couple more or a minute or two more. If there's no more commenters, we can end. I see it's labeled as Diane's iPhone, so I'm going to ask you to unmute yourself.
Hi there, my name is Diane Eamon. I am a practice coordinator for a pediatric dentist in the state of New Hampshire. And talking about the pre-authorizations, so you said you did some research on to where other states that did the pre-authorizations. I'm just wondering why you didn't research your sistering states, Vermont and New Hampshire, because they don't require pre-authorization. This is for deep sedations. You did Colorado. I can't remember the other ones that you did, but is there a reason why you didn't research your sistering states?
We did look at Vermont. We looked at Colorado, Illinois, Hawaii, Connecticut. I'm not saying that every state required prior authorizations exactly the same, but with clinical feedback, as well as looking at the prior authorization criteria and requirements of all of those states, we did decide to require PA for scaling and route planning. So that was just what we concluded.
And again, to underscore, as we go through the rulemaking process, that is the type of comment that can certainly be made and should be made through formal rulemaking, as well as through just this informal process of letting Henry know what your comments are right now. So we take that process seriously. When we review the comments, we look at potential changes to the policy. So that is the purpose. So we really appreciate the feedback, and we appreciate folks participating in the formal process as well.
I will add that if you're looking at this map of the United States and you're saying, why did they pick Colorado and Hawaii when Maine's over here in the corner, it probably doesn't make sense. But the states that we chose were based on provider input, and in particular on states that were deemed to have robust adult dental programs. Are folks generally cautiously optimistic about this, or no? In terms of, more providers coming on board, or existing providers taking on more members?
Kate?
So yeah, I'll say again, so this is Kate Hopkins again, in Community Dental. So we represent a pretty outsized footprint for this. And yes, we are certainly cautiously optimistic. So I don't want to, even though I was coming down on the PAs, I think from a rate perspective, it is certainly going to overall has a good potential of being a very big lift for us, and it's a needed one. And so, we're excited to see how this rolls out. I do think that we are also concerned on the flip side that it is going to, we already are, close to capacity in terms of our ability to provide care. So we're going to get a lot of other calls. And, I think our concern is that what's going to happen is clients will say, people calling us for services are going to be frustrated because they're going to hear Maine Care has expanded their services, and we're saying, well, we can't take you. And, that will reflect on us. There's a chicken and the egg, I recognize, and we needed to get the rates up in order for other providers to get out there and accept this, and for it to help us overall as our own organization, so that we can expand access by, expanding our provider pool, but that takes a little while for us to do. But overall, I'm pretty excited, or we're pretty excited.
Thanks, Kate. Beth's iPhone.
This is Beth Pierce from Maine Primary Care Association. Can you hear me okay?
Yes, we can hear you.
Okay. And I kind of echo Kate's comments. It's great. The benefit has been needed and desired for a long time. But on behalf of the FQHCs, much like the other nonprofits in the state, and both those two groups are really the majority of Maine Care enrolled providers for a very long time, they're really concerned about capacity. And, you know, we're trying in every way we can to support them in terms of workforce building and everything else. But the fact of the matter is the existing enrolled Maine Care providers are pretty much at their capacity. So there's a lot of concern about these adult members knowing that they have a benefit, but not being able to access it.
Thank you, Beth. Ellen?
Hi. Yes, I really agree a lot with Beth and Kate. And my big concern also is the need for the additional PAs at this point because of the volume of Maine Care patients we're already seeing at the Oral Health Center at UNE, and the staff to complete those PAs is going to be a big burden. I mean, we're seeing many Maine Care patients already due to our low fees for fillings and scalings and things like that. But to add PAs to crowns and some of the other items that are on the currently, you've removed the PAs for scalings, and now you're adding it back in, and just to have that additional volume, it's going to be very difficult for our staff to handle that with the amount of Maine Care patients we see.
Thank you, Ellen.
I think that it has to be looked at again.
And we certainly will. We're hearing that loud and clear, and we can take that back and reevaluate. Again, these are, you know, this is a draft proposed benefit. It's not final yet. We are hoping to finalize it soon, but any feedback we get here and in comments, we'll take into consideration.
Yeah, and just to echo what Henry says, we so appreciate all of your partnership in this effort, and we recognize that it's a slow process, but a really important one. And that's why we want to continue to have these conversations and really to listen to the feedback. But we are very appreciative of what you're doing now and of your willingness to work with us through the process.
I think Jessica is next. I'm going to ask you to unmute yourself.
I'm going to just add, I am Jessica Pila. I'm the executive director at Waterville Community Dental Center. And I'm just going to add to what the other people have said, but the prior auth process going online is chaotic, and it does take up a lot of time. So I think that's a huge focus on what I'm going after at this moment in my center, that we would have to look at hiring somebody to keep up with the prior auth process using your portal.
Thank you, Jessica. Beth Pierce, I don't know if your hand is still raised from previously, but if you'd like to make another comment, you can.
No, I just raised it again. Thank you. The other comment that I wanted to make regarding the scaling and root planing prior authorization requirement, where it was lifted through the PHC, it doesn't make a whole lot of sense to put it back on, especially when we're looking at an increase of 181,000 adults accessing this benefit, who most likely have not had any regular oral health care along. And so what they're probably going to be in need of before they can get into regular preventative care will be that full mouth debridement and that scaling and root planing. So if we can get these individuals into the practices, that is going to be one of the key and foremost procedures that they will need. So that would be probably the strongest argument that I would make for not having that requirement on that particular procedure.
Thank you, Beth. That's good feedback. Thank you. Let's see, Diane.
Hi, thanks again. Diane, I am a practice coordinator for 4 practices in the state of New Hampshire. So for pre-authorization for deep sedation, that was my first question. My second question is, because 3 of my other practices are outside of the 15-mile radius border, as a credentialed main care provider, I'm still required to do a pre-authorization for my other 3 offices, no matter what services I'm providing. Am I correct on that? Or can I see patients for preventative care in my other 3 offices because I am credentialed with you, but I'm outside of that 15-mile radius?
Hi, Diane. I think what you're referencing and what we've discussed before is that your one office is considered a READ provider, which is treated like an in-state provider, and your other 3 locations are beyond that 15-mile limit of the border, and under Chapter 1, they're considered an out-of-state provider, and all out-of-state services do require prior authorization at this time.
Okay. Okay. I was hoping that would change because our patients do go to our, would like to go to our Littleton location, and some of the services that we do provide are only provided in our Plymouth, New Hampshire location. So unfortunately, as a main care provider, again, that is putting a burden on staff that we don't have at this time. So we may not even be able to continue to be a main care provider, which saddens because, we're, as all the dentists are and the practices are in to provide care for patients in need. And doing those pre-authorization slows down the period of getting them in, as all of us are booked out right now as well. So to put that burden on the practices to do those pre-authorizations is something that we all have to look at to continue to provide main care to the main care patients. So thank you.
Thank you for that information, Diane. And as Henry has mentioned, please be sure to submit that comment to him as well. That would be very valuable for us to have that on the record. Thank you.
Thank you.
Melissa Watson.
I was just going to say, we were hoping to end by 6:30. Did I just go in and out and mute?
No. You, we heard you.
Okay.
We are hoping to conclude at 6:30.
Yeah.
But
Take Melissa's question, and again, everyone, you can send your. We encourage you to send your comments. This is really good feedback.
Hi, I'm Melissa Watson with Community Dental. And first of all, I do want to thank everybody. I understand that this was 30 years of neglect in our state that you guys are trying to clean up. So for that, we are very grateful for. And on the topic of the PAs, I guess my question is, we're thinking about our offices and the additional work that it's going to take to be able to do this. But is the state of Maine prepared for the amount of PAs that are going to be coming through? Because I remember 2 years ago when we had to do PAs for SRP, it wasn't a quick process for it to come back. And I wonder where that's going to put us now.
Tracy, any input here?
I think we have tried to anticipate what the impact on volume is going to be. As with any new process, I'm sure there is going to be some hiccups along the way. And, you know, I will apologize for that in advance and appreciate your patience and the ability to be able to work with you to overcome those challenges as we move forward.
Again, just to hop on that, as Michelle said at the outlet, this is the outset. This is such an important initiative. So we, you know, we will do all we can. It may not be perfect. It may be bumpy, but we think this is just a really important benefit to have. So we are prepared to make it a top priority.
And we have heard providers' concerns about pent-up demand and an influx of members coming to seek services. And words getting around, but part of our strategy here is to not go actively marketing the benefit too early to members, knowing that there's a capacity challenge. So we do anticipate notifying members, but in terms of actively promoting the benefit to members, we're trying to hold that back a little bit and really trying to hit providers first and to get everyone situated so that providers and members aren't frustrated.
Are there any last minute comments? If not, I did want to take the time to say we do really appreciate the feedback. I know I personally appreciate the feedback, and I will take a look at all of the comments sent to me and the ones that were submitted orally tonight.
Yes, thanks again to everyone for participating, and truly we appreciate all of the input and encourage you to continue to participate as we move forward with the formal rulemaking process as well. It's incredibly helpful to get that input.
Thank you, everyone. Have a good night.
Thanks, everyone.
Thank you.
Thank you.